you so much, Kim, for the very kind introduction. And I must say, as many of you know, Kim has done a huge amount to promote well-being of people with scleroderma internationally, as well as in the UK. So, Kim, I think we have to thank you. And I'd also like to thank Annabelle, Joe and Sue and everyone at SRUK for the invitation. I'm delighted that the meeting is in Scotland this year. I'm also delighted to see one or two old faces from Salford, and that's very nice. And I'm very pleased to be doing this, which is just down the road from where the Western Infirmary used to be that I spent many years of my life. So that's all good. So very nice ambiance here. So I'm going to talk about Raynaud's phenomenon and digital ulcers. I'm going to give a fairly general talk, and I know that many of you will know a lot already of what I'm going to say, but I thought it was important to be fairly comprehensive, and hopefully all of you will get something out of it, and I'm happy to take any questions afterwards. Now, I'm going to cover the different points on the slide. I'm going to talk about Raynaud's phenomenon first. I think I'll look at this slide here. What is Raynaud's exactly, and why does it occur, and how do we assess it? The same for digital ulcers. What exactly are digital ulcers, and why do people get digital ulcers, and how do we assess them? I want to talk about treatment of Raynaud's and digital ulcers, and finally give a few examples of recent and ongoing research studies. So first of all, Raynaud's phenomenon. Now, most of you will know this, but Raynaud's phenomenon is defined by the presence of colour change. So classically, there is a triphasic colour change from white, and that's due to vasospasm or constriction of the blood vessels. Then the fingers go blue or purple because the blood gets deprived of oxygen when it's stagnant. And then the reperfusion phase, when the reperfusion means blood flow coming back, it comes back. And as many of you know all too well, this tends to be the painful phase, the painful, tingly phase. And not everyone experiences all these three phases. They might just experience two phases, but the classic triphasic colour response is as shown. And it's usually in response to cold exposure or to emotional stress. And why do people get Raynaud's? Well, Raynaud's can be what we call primary, and that means that there is no underlying cause for the Raynaud's. It's not associated with anything. Or it can occur secondary to a number of different conditions, one of which, and of course importantly for many of you here, is systemic sclerosis or scleroderma. I'm going to use these two terms a little bit interchangeably. As doctors, we tend to say systemic sclerosis now, but scleroderma is an easier thing to say, and this is scleroderma and okay. But I'm using them today interchangeably. And it can occur secondary to other autoimmune conditions like lupus or myositis. And in this diagram here, this is not to scale at all, but essentially it just shows that the vast majority of people with Raynaud's phenomenon, and that won't be typical of this room here, but in the general population, the vast majority of people with Raynaud's have primary Raynaud's phenomenon. But a proportion have autoimmune Raynaud's phenomenon, that includes systemic sclerosis, and then some will have another secondary cause. For example, they might have an abnormality of their blood, or they might be in a drug treatment or have vibration exposure, and there might be some other reason for why they have Raynaud's. And it's up to us as doctors to work out why that is. And primary Raynaud's, that's a common type of Raynaud's, which, as I've just said, affects approximately 5% of the general population. It's an exaggeration of the normal physiological response to cold. I mean, I think everyone's hands get a bit cold in the cold weather, but Raynaud's is an exaggeration of that to the extent that the fingers actually change colour. And when Raynaud's occurs secondary to other conditions, and particularly we'll focus on scleroderma here, then it can be particularly severe for reasons that I'll discuss. And Raynaud's, of course, is itself important. It needs to have an underlying diagnosis, and it needs to be treated because it's a very, as many of you know only too well, it's a very troublesome symptom that has a major impact on quality of life, or it can have. But Raynaud's is important for another reason, and that's because many of you here will have experienced delays in having your diagnosis of scleroderma made. And Raynaud's is an important window of opportunity to make an early diagnosis of systemic sclerosis, because almost everyone with scleroderma has Raynaud's as a presenting feature. If you look back, that's often been the presenting feature, the first thing that people had. So if you carefully assess Raynaud's phenomenon, then you can sometimes make an early diagnosis. And again, I'll come back to that. And Professor Delgado this morning made reference to the VDOS study, which of course builds on that concept that if you examine patients with Raynaud's phenomenon and look for specific things, the VDOS, so-called VDOS criteria, then that can help you bring forward a diagnosis of systemic sclerosis. So how do we as clinicians assess Raynaud's phenomenon? Well, as always in medicine, we always take a history, or what we call a history. We ask you questions. We ask you about the colour changes of your fingers. Do you experience colour changes? What are they? To get some sort of idea of how severe it is, we ask about the frequency of attacks, how many attacks per day, per week, how long do the attacks last, how severe are they, do they impact with your activities of everyday living? Then we examine you, particularly your fingers. We want to look to see if there's anything abnormal. For example, maybe the finger's a little bit swollen, or maybe there's an ulcer, a little bit of loss of tissue at the fingertips. And all these things would all suggest to us that this perhaps wasn't primary Raynaud's phenomenon. We maybe had to think about a little bit about something else. And then we would do some tests if you came up to hospital. And we can discuss these further, but we usually do a panel of blood tests. And these include a test called the anti-nuclear antibody, or the ANA. And the ANA is negative in primary Raynaud's phenomenon, or at least it usually is. And that's reassuring, but because that would make systemic sclerosis very, very unlikely. But we do that. And we also do a test called nail fold capillaroscopy that Professor Church showed you an example of earlier. And I'm going to come back to that in the next slide. We also want to assess Raynaud's in the context of research studies. I'm going to come back a little bit to them afterwards. But it's very important in research to be able to measure whether or not people are improving. And there's been a lot of interest in this, and we have tools to do that. We have something called the Raynaud's Condition Score, which is a 0 to 10 score. And we also recently have got a questionnaire called the SRUK, which was developed by Dr. John Pauling from Bristol and others. And this is a 27-item questionnaire that maybe one or two of you have seen, and it encapsulates a whole load of the patient experience from Raynaud's, and we hope that that will help us to be able to measure how bad the Raynaud's is and how it might improve as a result of drug treatment. So I'm going to just spend a little bit of time on nail fold capillaroscopy, and one or two of you probably know this is one of my favourite subjects. This is a fantastic technique. Normally your little blood vessels, that's the capillaries, these ones here, are perpendicular to the skin surface, so you don't see them. If you looked at a microscope, you just see a whole lot of dots. But at the nail fold, they run parallel to the skin surface because of the anatomy of the nail fold. And in this person here, the nail fold capillaries are so abnormal that you can actually see them with the naked eye, and you can see some bleeding from them. That's very unusual. It's very unusual for them to be as large as that. So usually you need to magnify them up. As I say, in this particular individual, that wasn't really necessary, but usually it is. And so we can see, within the magnification, we can see the nail fold capillaries. And this helps us to distinguish whether someone has the common primary form of Raynaud's phenomenon or whether they might have systemic sclerosis. This can give us an insight. It's not everything, but it's a piece of the jigsaw puzzle that we have to consider. And nail fold capillaries are, nail fold capillaries by definition are normal in primary Raynaud's phenomenon. So here you see nice normal capillaries, whereas here are very abnormal capillaries. They're enlarged and there aren't that many of them. So this would be of concern to us, and we know that we have to look very carefully for an underlying diagnosis of systemic sclerosis. So now I'm going to talk a little bit about digital ulcers and how we assess these. So what are they, why do they occur, and how do we assess them? Digital ulcers are sores of the fingers or toes. And here you see two examples. And up at the top, you see an example of a fingertip ulcer. This is a particularly nasty fingertip ulcer. Ulcers are often much smaller than that. As I say, this is a marked example, but to demonstrate the point. So they often occur at the fingertip, but they can also occur over what we call the extensor surfaces of the fingers. This individual, as you can see here, has got marked contractures of her fingers because unfortunately she has severe systemic sclerosis with these contractures, very tight skin. And this means that the skin is stretched and over the ulcers, and that makes them liable to ulcerate. And we think that the reason that people get digital ulcers is because the blood supply is very poor in patients with systemic sclerosis, because not only do they just have this vasospasm of Raynaud's phenomenon, but they also have abnormalities actually of their blood vessel walls. And you saw that with the nail fold capillaroscopy. You saw these very abnormal small blood vessels. And it's very difficult to maintain your blood flow through these very abnormal vessels. And because of that, you know, the tissue becomes under stress and you can ulcerate. And you also can have low trauma. I don't mean by trauma a major injury. I mean repetitive stress. For example, these fingers here are going to be continuously subjected to mechanical stress because they're obviously exposed, the skin is stretched. And because of these reasons, the skin can ulcerate. Digital ulcers never occur in people with primary Raynaud's phenomenon. So if someone develops a digital ulcer, then you have to consider a secondary cause for their Raynaud's. And approximately half of people with scleroderma at some point in their disease course will go on to develop one or more digital ulcers. But if we look on the bright side of things, that means that approximately half of people will not. So it's not a given that you will develop digital ulcers. As Professor Church, as Colin said in his talk, you know, only a minority of people will develop pulmonary hypertension. Well, here you have a greater proportion that will develop digital ulcers, but it is a proportion. So don't think that you're going to get a digital ulcer. But I think it's important to be educated about them because sometimes we see digital ulcers presenting too late, and I'll come back to that point later. But it's very important that you know what you're at risk of, so that if this does happen, then you know that something needs to be done. Because digital ulcers, as many of you know far too well, are very painful and disabling, and they have a major impact on quality of life. So how do we assess digital ulcers? Well, in the clinic, you know, when we see you at the clinic, we ask you about the degree of pain, and if the pain's getting worse, that's obviously of concern to us. If it's getting better, that's encouraging that the ulcer is healing. We look at the size of the ulcer. Are they getting bigger or are they getting smaller? Again, are they healing or not? We always are concerned that digital ulcers might be infected. It might be obviously infected. There might be pus on it, you know, and it obviously, in that case, needs an antibiotic. Sometimes it can be more difficult to tell. But if there's any doubt, if there's a little bit of redness, and if the ulcer is very tender, then I always have a low threshold for suggesting an antibiotic because sometimes the underlying bone can unfortunately become infected and then that can be a major problem. So we want to try to prevent that happening. So early treatment of infection is important. And then we also have to consider the possibility that an ulcer is overlying an area of calcinosis. Some of you unfortunately here will have calcinosis. It's a complication of systemic sclerosis, these calcium-containing lumps underneath the skin. And sometimes these can break out and form an ulcerated area. And that's a particularly challenging problem because that sort of ulcer can take a long time to heal. But we have to be aware of the problem. And in research, as with Raynaud's, we have to think about how we can measure ulcers, and we can count the number of new ulcers. We can measure the time it takes for the ulcer to heal, although both these things, they might sound quite simple, but they're actually quite complicated, and it's an area that I'm particularly interested in. But, and then we can measure pain. We can use various pain scales to measure the pain of the ulcer to see if they're getting better or worse. And we can measure the degree of disability, the hand function, because digital ulcers have a major impact on hand disability. Will showed you pictures and showed you the impact on hand function of the skin thickening. And of course, it's often difficult to disentangle these because some of the disability might be coming from the skin and some from the digital ulcers. But we have to do the best we can. And there's a fairly new questionnaire that's been developed called the HDIS-DU, which specifically measures hand disability due to digital ulceration. So I think that will be helpful in future research studies for tracking change over time. Okay, so now I'm going to turn to treatment. And that's, of course, what we want. We want to be able to treat Raynaud's and digital ulcers as effectively as possible. I've rather lumped them together, and they are separate entities, and I accept that, but they're interrelated. And really, the treatment pathways are such that the treatment of digital ulceration depends, first of all, on adequate treatment for Raynaud's phenomenon, because for reasons that I've just said, it's important to try to get as good blood flow as possible and treat the Raynaud's as well as we can, so that we will hopefully not get into the problem of digital ulcers. So the two are very much linked, as I'm going to show. So these are the general principles of treatment, and I'm going to go through each of them in a bit more detail. But the first problem that we have to tackle in treatment if a patient comes along with Raynaud's phenomenon, someone comes along with Raynaud's phenomenon, is actually to establish the diagnosis. Why does that individual have Raynaud's? Because there might be a cause that's amenable to treatment of that cause. For example, there might be a blood disorder, or there might be another condition that is actually treatable in its own right, and by treating that you will have removed the problem. So you always need to think about that, and that's one of the first principles. But having made the diagnosis of why the person has Raynaud's phenomenon, or why they have a digital ulcer, then you go ahead, and the first thing is general non-drug, sometimes called conservative measures. And these are very important. I'll deal with them on my next slide, but they sometimes get forgotten about. People tend to focus on drug treatment. But drug treatment is only one aspect of the, one element of the treatment of Raynaud's and digital ulcers. And then a minority of people with systemic sclerosis or scleroderma require surgery or procedural treatments for digital ulceration or for very severe Raynaud's, but that's not indicated for primary Raynaud's phenomenon. So I show this slide here because I just want to reassure you, and I think this is good news, because these two sets of recommendations which I demonstrate here, the recommendations from the British Society for Rheumatology, and they've just had their annual meeting here in Glasgow the last 3 days, and here's EULAR, the European Alliance of Associations for Rheumatology. Both of these organisations have very recently published new guidelines or recommendations for the treatment of scleroderma or systemic sclerosis. But within each of these guidelines or recommendations is a section on the Raynaud's phenomenon and digital ulceration. And I think it's good because in both these subsections there are changes from the last set of guidelines. And I think that's important. I think it's important that you all know this, that there have been advances in the treatment. So although we would much like our treatments to be more effective, there are improvements being made. And I'm not going to go through all the slides here. I'm going to come back to these points. But this is a cartoon from the EULAR paper, which was Professor Denton at Royal Free spearheaded the BSR guidelines. Professor Delgado, who you heard earlier today, spearheaded the EULAR guidelines. And this is a diagram from Professor Delgado's paper. And I simply put this up here. This is just about drug treatment. It's not about other aspects of treatment. But here's the treatments for Raynaud's phenomenon that we're going to go through in a minute or two. But I just want to make the point that you go through all this, and then, you know, if the person develops a digital ulcer, then you go through the pathway here. But that's on top of the pathway for Raynaud's phenomenon. So the two are interrelated. So that's why I'm dealing with them together. But first of all, the general or non-drug measures. Patient education, this was mentioned earlier by Lorraine and by, in fact, Will indirectly in some of the other talks. This is hugely important. So a huge thank you to SRUK for producing all these terrific leaflets. You know, it is very hard. We've heard this earlier. You've got a very short doctor's appointment, so we can't cover everything in the context of an outpatient clinic, and it's very often overwhelming. Everyone's going to forget what they're told. We completely accept that. But it's a great boon to us to be able to signpost you and give out leaflets at the clinic. And there are a lot of very good leaflets, including those on Raynaud's phenomenon, digital ulcer, handy hints on keeping warm. So I'd encourage you to read these. And, you know, a lot of general measures are common sense. You know, we have to try and avoid triggers, but we have to go about our everyday lives. So we can just mitigate the effect of cold by keeping warm gloves, socks. Don't forget to keep warm centrally. Occasionally we see people wearing gloves and then they forget, you know, to wear socks, and they forget to have nice warm clothes on centrally. We've strongly discouraged smoking for those who still smoke. And specifically for digital ulcers, and this will come in my next slide, it's important to alert someone if you develop a digital ulcer early. And of course, wound care is an important aspect of digital ulcer care. So we're very grateful to our specialist nurses and tissue viability nurses for helping us out with that. Now, I show these next two pictures about seeking advice early. I think mobile phone photography is great. And these two pictures were taken during the pandemic. This was a young woman whose care I was involved with. And, previously, I think prior to the pandemic, people would ring up or get in touch with us and we'd say, well, come up to the clinic on Friday or whatever. And they'd be seen fairly quickly because the digital ulceration can be a medical emergency. But that wasn't really practical during COVID because nobody wanted to come up. So we established a system whereby there was a dedicated email number to send photographs to. And this was, really nasty digital ulcers. And here's one that's obviously infected. And with the purposes of a phone call and these pictures, we obviously knew that there was a significant problem. And the patient was fortunately operated on, had a surgical debridement within 2 or 3 days of sending us the photographs. And I think that taught us a lot, because I think a lot of you travel long distances to your hospitals, and I think it's very helpful to see these photographs, because I think that allows us to manage things effectively at convenience for all parties. And I think now we're looking at far more mobile phone photography and mobile monitoring. I'll come back to that a little bit also in the research scenes. So I think that's become a major advance. So now we're going to talk about drug treatment. So we've talked about making the diagnosis of digital ulcers early and about the general measures. So now we're going to turn our attention to what drugs. And of course, many of you will be very familiar with these because you'll be on drug treatment for your Raynaud's. So there are a lot of different drugs that are available. And I think that consensus of opinion is that the first-line treatment for Raynaud's phenomenon, for people who require drug treatment, a lot of patients won't require drug treatment. Certainly, probably the majority of patients with primary Raynaud's phenomenon will probably not require drug treatment. But if it's severe, then that can have a major impact, and they will. And most patients, in my experience, with Raynaud's related to scleroderma probably will require drug treatment. So we usually start off with one of a group of drugs called calcium channel blockers, and these are drugs, for example, nifedipine, that many of you will have heard of, or amlodipine or beyond already. And we always start low. Start in a small dose and gradually build the dose up, because unfortunately these drugs don't just act on your fingers and toes. They have a general effect. They widen the blood vessels generally, so they can make you feel a bit dizzy or flushed or give you a headache. So it's important to start with a small dose and gradually increase the dose to what we call your maximum tolerated dose or required dose. So if for some reason a calcium channel blocker is not sufficiently effective, or if it causes side effects, then we need to consider another type of drug treatment. And if it was ineffective, but maybe it was partially effective, but not that effective, we might add something in. If it caused side effects, then we would substitute another type of drug. And there are a lot of different drugs, and we can discuss these. But unfortunately, the evidence base for the different treatments is pretty small, because it's very difficult to establish on an evidence base. That's a whole separate talk in itself, which I'm happy to discuss in the questions. But suffice it to say that there are different drugs available, but there are very few of them that are licensed for Raynaud's phenomenon because we don't have that good evidence. I think there is a consensus view now that drugs like phosphodiesterase type 5 inhibitors, for example, sildenafil, which was mentioned by Colin, used in the treatment of pulmonary arterial hypertension. I think now most of us in the scleroderma world would consider that these are now second line to a calcium channel blocker for systemic sclerosis-related Raynaud's phenomenon. So we use a lot of sildenafil now, and I think it's probably very effective for Raynaud's phenomenon. And it's also effective for digital ulceration. So I think sildenafil and a drug called tadalafil are used more and more now in people with scleroderma. If people continue, despite that, to have recurrent digital ulcers, these are individuals with systemic sclerosis, then we have another drug which some of you might be on called bosentan, which has been shown to reduce the number of new digital ulcers, so we can prescribe that. And some of you might have had intravenous iloprost. Sometimes that's required, But we use it far less now because we have more effective oral treatments. So I think the need for using intravenous iloprost is much less, and I think it was used much less during the pandemic for obvious reasons, and I think it's less used now. But it definitely has a place, intravenous iloprost. For example, if you have a nasty acute ulcer, or if you've got a permanent discoloration of fingertips, then you need to be admitted for intravenous iloprost, and your doctor will arrange that if he or she feels that that's what's required. And surgery is really very small print. It's really unusual to require surgery. But some people with scleroderma and nasty digital ulcers will require surgery. And the commonest form of surgery, in my experience, is what we call debridement. That's essentially a cleaning up procedure. It's the surgeon, scraping the dead tissue and cleaning up so that you can allow healing. And the lady whose pictures I showed you earlier, she had a debridement of each of the ulcers that I showed, and they heal very well afterwards. So it depends where you practice a little bit, but certainly in Salford, where I was for many years, where Will, who's just spoken to you, is, where there's a very good multidisciplinary team, very good hand surgical input. There certainly were a lot of the surgical debridements done. There are more complex surgical procedures. There's a procedure called digital sympathectomy that's sometimes used, but this is a highly specialised procedure, only to be done by a very experienced surgeon with experience in the technique. And Botox injections, I think, were mentioned by someone earlier on. And Botox injections are interesting. There have been a lot of papers in the literature. I think it's difficult. I think the jury's out as to just how effective it is. But certainly, several people say it's effective and or find it's effective. And I think that it will be interesting to see how that all pans out in the next few years about Botox injections. But they are used, and I think they can be helpful in some patients, especially those who have gone on to develop digital ulcers. So in the last few minutes, I'm going to give some examples of recent and ongoing research studies. Now, why do we need research? Professor Delgado gave a very nice talk this morning about clinical trials. That's one aspect of research. So clinical trials, looking at treatment trials of new treatments are one aspect, but there are a lot of different aspects of research. And we do research essentially to find better treatments. That's the bottom line. But we have to unpick that and look at a lot of different stages in the process before we can suddenly try out a new treatment. And we know that the treatments aren't sufficiently effective for many people, so we do need new treatments. And there are a lot of different studies, and maybe not as many as we would like, but there are several studies underway or have recently been completed nationally and internationally, and I'll just share some of these with you. They've got a little bit of a bias towards ones that I've personally been involved with. But specific examples of types of research studies, well, we've talked about, and many of you know only too well, the problems of a delayed diagnosis. We're trying to move that diagnosis earlier so that people can get diagnosed earlier, so that they can have the benefit of patient education, of early identification of internal organ involvement and treatment at an early stage. So that's important, so research into that, and I'll come back to that. Measurement is important. If you can't measure a disease, then you can't study it. Raynaud's and digital ulcers are notoriously difficult to measure. It's challenging to do clinical trials. I'll come back to that. But that's been one of my major interests, has been measurement of these different conditions. And we want, as we said earlier too, and Professor Delgado spoke about this, about developing new approaches to treatment via clinical trials. So what about trying to make an early diagnosis of systemic sclerosis? And Professor Delgado has already mentioned the VDOS study. And this was a huge international study which he was very heavily involved with. And that was trying to pick up what, amongst people with Raynaud's phenomenon, what were the features that would worry you, that would make you think this person is at high risk of developing systemic sclerosis? And the VDOS study showed that in patients with Raynaud's phenomenon, then the red flags, as it were puffy fingers. If someone's got puffy fingers, that's persistently puffy fingers, that is. I mean, everyone gets puffy fingers if they're on a really hot day, but persistently puffy fingers are a concern. ANA positivity, I mentioned earlier, and the positive anti-nuclear antibody, that's a concern. If someone has a more specific, what we call autoantibody, it's a type of protein in the blood. If you have what's called a scleroderma-specific autoantibody, and someone mentioned earlier today an anti-centromere antibody, that's one of the scleroderma-specific autoantibodies. If you have a systemic sclerosis-specific autoantibody, or if you have abnormal nail fold capillaries, which I showed you examples of earlier, these are the four sort of VDOS criteria, and these would make us feel that 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 person needs to be followed up because they're at risk of developing systemic sclerosis. The other study that I'd like to mention is an ongoing study. It's the ulcers study. It's a nail fold capillaroscopy study. It's one that I'm very heavily involved with, automated capillaroscopy, evaluation of Raynaud's and systemic sclerosis. And we mentioned nail fold capillaroscopy. The problem is that a lot of doctors, a lot of rheumatologists don't use nail fold capillaroscopy. Everyone's busy. And there are challenges in nail fold capillaroscopy. You need to know how to acquire the images. You need to have equipment to acquire the images. And you need to interpret the images. And these all have their challenges. So we're trying to sort of break that down so that it's easier for the rheumatologist at your local hospital to be able to do nail fold capillaroscopy and have an interpretation rather than send you off to a tertiary referral centre that might be 200 miles away. So this is looking at automated capillaroscopy. It's trying to look at an automated system of guiding users to acquire the images in the first place. Then the vision, as I say, this hasn't happened yet, but the vision is that will then ping up to a cloud somewhere up there, and then seconds later will come back a report that gives a probability of having, having an underlying systemic sclerosis. So that study is currently ongoing in 7 centres in the UK. Grampian is one of the centres, so anyone from Grampian, if you're interested to participate, there's an opportunity for it. So this isn't a clinical trial, but it's a clinical research study. So lots of research going on. And so actually, I'll just come back to that slide in a minute. I didn't go through it in any detail, but there's just that shows the computer. This is completely automated, no human input at all. The machine learning approach, an artificial intelligence approach, picks up the capillaries and does all these fancy things to you and computes out a density and a probability. So measurement, I said measurement was important, measurement of disease process, and we're making headway there. At the end of the day, symptoms are important, and John Pauling, I mentioned earlier from Bristol, has developed the SRUK questionnaire. This is the reference for that. So I think this will be good because I think we can use this. It captures the patient experience of Raynaud's phenomenon, and it's already being used and currently running clinical trials of Raynaud's. In Salford, where I worked for many years, and I still have an affiliation with, we've been very interested, as I said, for in a smartphone app. We've developed this. It's still got work to be done. This is pending, but we've gone quite a way down the road already. And, when patients come up, Professor Raynaud mentioned this, you tend to come up every 2 or 4 weeks for a research study. But if it's a study of digital ulcers, if you look at treatment for digital ulcers, then maybe the ulcer heals the day after your visit, or maybe it heals the day before the next visit. And that might be 4 weeks apart, so you don't know whether the ulcer's healed the day after or 4 weeks after. And so it's not a terribly sensitive indicator. So we just thought, because everyone was giving us photographs of ulcers, and it would be a good idea to try to capture this. And we've done this. This is an example, it's in the published literature, of someone. We asked people to photograph their ulcers every day for 30 days. Here you are here. You won't be able to see this probably at the back. But essentially you've got an ulcer here that stays the same for a while. But then it gradually gets better, and by the end of the 30 days, it was more or less healed over. So we're very interested in exploring this as an outcome measure, because it's an outcome measure that you can do in your own homes. You capture it on the app, and then it just all gets pinged off to the investigators. And I think this could be a way forward for measuring digital ulcers. But it's actually, again, like most things in life, it's more complex than it sounds. But that's work in progress. And finally, treatment studies. Professor Glasgow mentioned treatment studies. I'm just choosing an example. This is a study, the most recent treatment study that I was involved with. It was looking at, and I just wanted to use this as an example of a treatment study. So clinical studies of Raynaud's and digital ulcers are very challenging. They have to be done usually Raynaud studies usually have to be done over the winter months because, of course, it's very seasonal and people tend to get a bit better in summer. So you could get an effect just because the weather gets warmer. So it means that we have to cram these studies into winter. And as I said earlier, it's difficult to measure Raynaud's. So for all sorts of reasons, it's very difficult to undertake studies in Raynaud's, but that's possibly why there have been so few studies in Raynaud's. But this was a recent example of a company which was looking at a preparation of a drug called treprostinil. If you look very carefully at Professor Church's slides this morning, you just might have seen treprostinil in his treatments for pulmonary hypertension. This is used subcutaneous, that's by injection. Subcutaneous treprostinil is used in pulmonary artery hypertension. And this company developed a sustained release preparation, that would last for probably 7 to 15 days, and wanted to ask us if we would trial it out. And we did do that. It was a small study. It was what was called an open label study. Everyone got the treatment. So it was he showed you the different phases of treatment. This was an early phase 2 study. Everyone got the treatment. All we were looking for was a signal of benefit. And had there been a signal of benefit, then the company would have wanted to take it on to progress it through to a more definitive clinical trial. And in fact, it did work. You have to be very careful about open label studies because there is a placebo effect. But the Raynaud's condition score went down, more than the difference that we would be looking for. And there were also benefits, and we did some quite sophisticated temperature measurements, and there was also benefit there. But unfortunately, there were quite a lot of injection site reactions. I don't know if anyone's had subcutaneous treprostinil here, but it is very irritant. And in fact, that was a problem with the injection. It was irritant. And so I'm not sure for that reason whether this will be taken forward, because that's something that has to be got around, because everything is a risk-benefit ratio. You have to do the advantages and the disadvantages, but I just mention it because that's how we learn. And if any of you do have the opportunity to participate in a clinical trial, I'm obviously a little bit biased, but I'm a great fan of encouraging participation. There is never any obligation. But if you are interested, then I think it's good if you can participate in a clinical trial, because I think that's how we learn about developing new treatments. So sadly for this one, I'm not sure unless it can get a less irritant formulation. But we'll see. But I just want to reassure you that we are doing these clinical trials. We are trying to advance the field. Because had that treatment been effective, then it might have saved people having to come in for intravenous iloprost. They could just have a subcutaneous injection. But anyway, there we are. We keep hoping and we keep trying to develop new treatments. So I've covered the different points on the slide: Raynaud's, digital ulcers, treatment, and examples of studies. I'd just like to conclude by saying that if we assess Raynaud's phenomenon, we have to decide whether it's primary or whether it's secondary to one of a number of different clinical conditions. And it's important to diagnose any underlying condition as soon as we can, so that if it's treatable, then we do that. Or if it's systemic sclerosis, then we put all the monitoring and investigative approaches into place. Only people with secondary Raynaud's go on to develop digital ulcers. So if you have primary Raynaud's phenomenon, then be reassured that you will not get a digital ulcer. Of course, we don't have a crystal ball. People who sometimes have primary Raynaud's, unfortunately, do sometimes years later go on to develop worsening of their Raynaud's. That's unusual. It's unusual for primary Raynaud's to get worse later on. So if it does, we always just worry about that, and we always reassess things. But we have to always assess digital ulcers. Treatments are available, but they're not as good as we would like them to be. And for that reason, we continue to do research studies with the aim of, trying to make early diagnosis and trying to develop new effective treatments. So I would like to acknowledge SRUK for all the support that they've given the research in this country, and the two merger organisations, the Scleroderma Society and the RSA in the past, who have really, I think, helped people in this country to develop studies. Certainly early in my research career, I was very helped by grant funding from the organisations. I'm very grateful to them. The capillaroscopy work that I described, it's currently funded by the NIHR, the government research organisation, but the early capillaroscopy work was certainly funded by what was then the RSA. And we're very grateful for that, and that's how we learn. And we're delighted to see you all at these meetings, and hopefully disseminate information and wave the flag. So thank you very much. I'm happy to take any questions.